We're now commencing the next session, which is looking at a few different perspectives of OPAT HITH, which are extremely important, obviously, to their success. And so I'd like to introduce Pauline Dobson. So Pauline is a nurse consultant in the Immunology and Infectious Diseases Unit of John Hunter Hospital, conjoint lecturer with the University of Newcastle. She has over 30 years experience in ambulatory IV therapy, 23 in OPAT. She presented more than 80 conference papers, a number of peer-reviewed articles on IV-related issues. So Pauline's going to talk to us about nursing and vascular access considerations in OPAT and HITH. Thanks, Pauline.
So, choice of vascular access device. Well, it's a multifactorial thing, decision that's made. The intended duration, whether the person has vascular access issues, whether you have access to timely insertion, for example, if you're choosing a PIC or a midline, and the cost, which is particularly relevant to rural HITH services who don't have particularly large budgets, and so sometimes PIC lines may be way out of their reach. There's a recent study that was done in Queensland on the costs of different devices. Unfortunately, midlines are not in there, but peripheral cannulas, that's just insertion and removal costs, and the staff to insert and remove, not the maintenance costs. So you can see there's a big difference between a PIC and a peripheral cannula, and of course ports are much more expensive but lasts a lot longer. So there's a lot of discussion around peripheral cannulas and safe continuous IV antibiotic administration. So this paper that was done by the Canberra Hospital, King et al. They did continuous infusions in peripheral cannulas. Average draw was 3 days, maximum 8, 100 patients, 192 cannulas, and 552 catheter days. So 6% failure with dislodgement, tissue, occlusion, kinking, and pain. But that works out to a complication rate of 21.7 per 1,000 catheter days, which I'd like you to sort of put in your bank for later on when we're talking about other catheters. And then there was a poster done by Calvary Health at Home, which is another Canberra hospital, and they did 50 patients with kefazoline, benzopen, tazocin and meropenem, 1 to 15 days. Mean duration was nearly 6 days. 20% were removed for pain, leaking or blocked cannula, and 20% dislodged. And then, of course, there's phlebitis, which is extremely painful, can lead to sepsis, and is common with flu clots given peripherally. And Brian Agnew found 29 cases from 59 flu clots versus 2 of 25 kefazoline. Some had PICs, but most had peripheral cannulas, but she didn't specify which of the catheters that the patients had in when they had their phlebitis. And these are some of our inpatients with flu clots phlebitis. So the next is midline. So for those uninitiated, it's usually 8 to 20 centimetres in length, terminates before the axillary vein, distal to the shoulder, may be inserted using similar techniques to PIC lines like modified Soldiner. So why use a PIC line? And the people that go with midlines believe that insertion is cheaper because a chest x-ray is not required. But if you insert PICs using the technology that ECG tip location, then there's no chest x-ray required for them. The PICs have more complications, so proponents claim a 30% failure rate with PICs, and I'm going to talk about that a little while later. That the infection rate is lower in midlines. And so I say we're not comparing apples with apples. In Mackey's study in 2006, the midlines had half the dwell time of PICs. So if you're not, the catheter's not in as long, therefore they're not exposed to the risk of complications for as long. And other studies have much shorter dwell time. And I think if anybody's reading articles about midlines, you really need to examine the dwell time. So this was a study that was presented at one of our HITH conferences, and it was looking at midlines compared to PICs in cystic fibrosis patients. And you can see the complications in the PIC line group far outweigh the complications in the PIC group. And so they had 18% of patients with midlines had one or more adverse events, which resulted in a 14 per 1,000 vascular access days, and 15% of patients with PICS, which was 11 per 1,000 vascular access days. And then another paper via the Australian Vascular Access Society, midline catheters for prolonged antibiotic therapy. There was just 67 in this for antibiotics, and if you look at those that reached the end of treatment, no longer required, it was only 63%. So we had a 37% failure rate. So because I thought that was very odd, 1 in 3 PICs failing, I thought I would have a look at our data. So this is 2018, and so the rate for all our nurse-inserted PIC lines is 3.6 per 1,000 vascular access days. That's hospital and home, and if we look at our home PICs only, it's 1.7 per 1,000 vascular access days, so a lot different than 11. And it's also 7% of PICs. So here's another study that quotes this: after PIC insertion, PIC failure is as high as 30%. So this is from the Avatar group, which is a Queensland group that is internationally renowned for the vascular access research they do. They do more than anybody else in the world. And I thought, I don't understand this, so I went to the reference, and it was actually from a review of paediatric outcomes with PICs, and you can see that 16 of them were in NICU, the studies, 6 were in haematology oncology, only 3 were in outpatients, and some of these had gastroenterological failure, which is more likely that they had TPN, and we all know that the complication rate with TPN is higher in PICs. So they did a study with the Brisbane Women's Hospital and Metro North HITH, and they actually found a 10% failure rate. So the statement that often gets repeated in the literature, so people put this 30% failure and then it gets repeated in the literature, but that's not the case with adults. And they actually had 32% had dual lumen PIC lines. So we don't put dual lumens in people going home for antibiotic therapy. Sometimes St Elsewhere's will send us one, but we certainly don't do it ourselves. And so I wanted to get across that all PICs are not equal. So these are our nurse PIC team outcomes. So if you look at Arrow single lumen, 7.7 per 1,000 vascular access days, this is failure rate. Arrow dual lumen, 16.7. PowerPIC Solo, which is the current one we use, 5 per 1,000 vascular access days, and dual lumen 10.1, so double the risk if it's dual lumen. And BioFlow that we've used in the past, 8.7. And then location managed makes a difference. So when you're reading a study, make sure that you know where the PICs or the vascular access devices were managed. So in this one, you can see that for all complications other than proven infections, there was obviously a statistically significant difference between failures in hospital compared to those at home, which doesn't surprise us because the more serious patients stay in hospital. With proven infection, there was no significant difference because there's such a low rate. So then we'll look at clinician versus self-administration. So the first HITH started in the 70s as self-administered IV antibiotics, and these days there's mounting evidence to support self-administration in the articles there on the right, and supervised self-administration is in the New South Wales HITH guideline as an approved model of care. But still the bulk of OPAT is clinician administered, except in our service where for the last 10 years, 50% of our patients are self-administered. So in 2014, Dr. Lowenthal and I did a survey of HITH services and their vascular access practices, and 18% were training patients at that time to self-administer. So if we look at the available evidence in the literature and our cohort that we haven't yet published, but one day we'll get it there. So there's actually in this group over 15,000 either admissions or individual patients that have received self-administration. Some of them don't have a comparator group, and some are in niche things like infective endocarditis or geriatric patients. So this is our OPAT cohort looking at all line complications, and you can see that the only significant difference, so the clinician administered is the dotted line and self-administration is the solid line. And so you can tell there's a difference with phlebitis, accidental removal and thrombosis. With the accidental removal, it just means that we're sending people home to have a clinician do it, and they may be a little more confused. So what this tells us is that we're choosing the right group of people to do self-administration, and we're choosing the right group of people to have a clinician. It doesn't mean that clinicians are doing things worse than patients. But at all points there was clinicians had a higher risk of catheter removal for complications. So compounding, commercial compounding, shelf life is longest possible and it's verified, and they have rigorous monitoring of their sterile compounding suite. They'll deliver to the facility or the patient's home, although sometimes the time from order to delivery is a problem and a high cost. If you use a local pharmacist in your facility, they're using the same sort of sterile suite, although probably not to the same level as the commercial one. Although the cons, particularly in our service, there's competing demands for sterile suite time. Sometimes it's a problem with availability of compounding pharmacists, and certainly immediate compounding is not possible because they're often doing like a run of chemotherapy or something, and they won't interrupt it to do a vancomycin where a dose is changed. Nurses, so immediate supply is achievable, sterile suites not required, extensive training is not required because it's something that they're used to doing on the ward. But it must be used immediately after compounding, so you can't make it up and then travel 4 hours to someone's home. So we were the first to use the sterile saline infusers for compounding in Australia, and so we've been doing it since 2007, and since then we've compounded more than 4,000 elastomeric pumps and presented a couple of papers on, and one that Mark had up earlier. And at the last HITH conference, Wide Bay in Queensland presented their outcomes. They started in 2015. So in the paper, there's clear guidelines that we outline about nurse compounding, and so it's only a stopgap measure until a supply of commercially compounded electric pumps is available, because we want to just give a patient 7 days worth so that they can go home. And it's very time consuming for nurses to be compounding, so it's not something that they could do in bulk every day. And of course our outcomes showed no difference in infection between the pre and post compounding time period. And when we did our survey, 41% of HITH services that responded to the survey in Australia said that they were, and another 2% said they wanted to, but not yet. So if we look at pumps, these are all horses for courses. Everybody does things that are particular to their service and their own needs, etc. There was a Wide Bay poster that Watson looked at performance. Even though it says peripheral cannula, they actually looked at the pump performance, and lo and behold, they found that electronic was better than elastomeric in delivering the required amount of antibiotic. Well, we would all know that. Then Lin, Tang and Bernhardt found that the elastomeric was better than electronic due to the time change of an infuser versus loading an IV bag and programming an electronic pump, which is what they had been doing in the home, and they found they made a cost saving by swapping to compounded. So it's horses for courses. And when Mark and I did the survey, so the number of patients with central venous catheters having home IV antibiotics by service ranged from 0 to 28. 88% of HITH services did 24-hour continuous, and 68% of them did elastomerics only, 5% electronic pumps only, and 28% both elastomeric and electronic. And there was a poster that was done by Central Coast LHD that looked at factors affecting antibiotic delivery from a portable continuous infusion device, so elastomeric pumps, and as has been stated earlier, those infusers that are emptying early, if it's summer, there's a greater percentage of them emptying early. If it's under the blankets, 55% emptying early, and then infusers emptying late, and autumn and winter is 78%. So the ambient temperature does make a difference. And here, they're on top of the blankets, 56%. The limitations of their study was the difficulty recording exact volumes remaining, patients recording the time they first noticed their infuser was empty, and we all know that patients get up at all different times of the day and they may not look in their, at their pump until after breakfast or something like that. The daily temperatures in the area weren't recorded. They relied on general seasonal variation, and also line issues weren't recorded, which is often what our on-call nursing service will find. If it's not deflating properly, there may be a kink in the line. So first dose at home. There was a Canadian study. They used their ADR database, which is a voluntary database, but over an 8-year period of time, looking for first dose anaphylaxis only, not specific OPAT. So they found 386 of these. Only 27 of that were IV antibiotics, which is somewhat reassuring, but still concerning was that cefazolin was the most commonly indicated in 7 of the reports. 14 of these 27 were first dose or on the first day of administration, and 2 of these resulted in death. That was cefazolin. However, patient data was missing, so they didn't know if those people were actually had previous reactions to the same class. So when they did this paper, they also surveyed OPAT services in Ontario. 72% give the first dose in the home on a case-by-case basis, but patients aren't approved for OPAT if they're taking beta blockers or antiadrenergic drugs. In their discussion, they pointed to the fact that severe anaphylaxis to all drugs is like 135 per million hospital inpatients. 57% of this is in the first 2 days and 75% in the first 5 days. And if you do have severe anaphylaxis, the mortality is 5%. So Horst, who's up the back, who's presenting later, looked at this as well. And so 221 out of 335 safely received their first dose at home or in a residential aged care facility. There were 4% ADEs reported and 2% allergic reactions, and all managed appropriately with no anaphylaxis. So all allergic reactions first reported from home and none at the time of the first dose. So they'd had their first dose like in ED and then had their reaction. So when we did our survey, there were only 7% of HITH services that were reported that they were giving the first dose in the home. Of interest in this is a legal case, Applewhite versus AccuHealth, which was 1998, where a home infusion nurse was sued after a child had anaphylaxis for not carrying epinephrine. So the home infusion service would deliver all the supplies to the patient home, and the nurse just turned up and administered it, but she was sued because she didn't carry adrenaline. It's a bit of a precedent there. So in 2004, our service looked at allergic reactions, and one of our co-authors is one of the immunologists from Immunology Infectious Diseases. And so you can see that the ones that occurred within 3 days, there were very few. Ours is a long-term IV antibiotic service. So that was 1,000 admissions, and single antibiotic 868, dual 124, and triple 8 admissions, 90% given as continuous infusions, which can impact on the rate of anaphylaxis, 6% intermittent and 4% bolus. No true anaphylaxis. Time from start of the drug to reaction was 19.6 days, a median. No rash was exfoliative or bullous, and all the episodes of perioral angioedema involved slow onset with limited swelling, which responded rapidly to antibiotic withdrawal. So, injecting substance users and OPAT. So, They commonly require long-term antibiotics for serious infections, sometimes relating to poor injecting practices. So injecting drug users or substance users frequently excluded from OPAT. And in this paper from Barwin Health, Dr. Pollard and Lunn, it was presented at 2016 conference, they found 27% tampering rate and 55% readmissions. So this recently, only a couple of months ago, there was a review article that looked at all the literature that's over here, including our paper, and so they had 800 OPAT episodes. 3 large studies found no significant difference in rates of treatment failure, readmissions or long-term outcomes, and the catheter-related complications range from 3% to 9%, or 0.75 to 4.2 per 1,000 catheter days. So no significant difference in catheter-related bloodstream infections compared to non-IDU on OPAT. So how do you decide who to accept? And apologies to those who were at the HITH conference in November last year where I presented this paper. Along with 2 drug and alcohol doctors, I developed a tool that is a screening tool assessing the risk to injecting substance users, not the risk to the OPAT nurse, the risk to the injecting substance user if they're accepted onto HITH. And it looks at their injecting practices and whether they've got a history of overdose, what they're injecting, and if they have any chaotic behaviour, and you score on the right-hand side. And if you've got 8 or more, then it would indicate significant risk if you're admitted to HITH. And I do have some copies of the tool if anyone wasn't at the conference and would like a copy. On the reverse, it's just got the CNS depressants and the Glasgow Coma scale. So independent double checking. So the New South Wales Medication Administration policy says that when medications for injection are administered by a nurse in a patient's home, such as hospital in the home, the second person must check must occur within the health facility. So before the OPAT nurse leaves to give it in the home. So OPAT nurses work independently. Wrong patient is generally not an issue. So elastomeric pumps are commercially compounded, and in that context they're checked by the pharmacist at the compounding facility. They're often checked by a pharmacist at a local hospital prior to dispensing. Then they're checked by the nurse prior to taking to the patient's home, and checked by the nurse prior to connecting to the patient. So there's a lot of checks there. With bolus medication administration, that's more problematic, particularly if part doses are constituted. So it's usually undertaking before leaving the HITH service, and if you have to do a part dose, then one of the ways around it is by telehealth, but I'm not sure how many HITH services are doing that to get their administration checked. So there's been a few papers recently looking at the evidence for double checking, and this paper said there is insufficient scientific evidence to justify double checking of medicines and clinical trials are needed. And then this randomised controlled trial was actually done in simulation, in a simulation lab where they just observed nurses who were double checking. And so they supported double checking, but they said even when using the double check, the second nurse can mislead the first nurse and provide false reassurance, and that happened in 3 cases in this study. So in some instances it's still for decision making. And then we'll look at occupational health and safety, but it's not definitely least. So lone practitioners, cluttered homes, presenting hazardous workspace for home infusion therapy, sharts management, aseptic technique, bending over people who are sitting in lounge chairs, so for, say, 20 minutes while you're fiddling around with a PICC line, distractions while providing care. And in this paper, one of the patients had a parrot flying around the room screeching. At-risk neighbourhood areas, home oxygen in COPD patients who are still smoking, which is quite commonplace. Isolated rural properties, which is a big thing for us here in Australia. Poor or absent mobile phone reception. And in the inner cities, we've got parking, traffic and road rage. So thanks very much to my colleagues who are brilliant staff out and about, and my co-researchers. Thank you.